Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. Gamma pod treatment, a new therapy for breast cancer. Find out about it right now. My guest this evening is Dr. Elizabeth Nichols, the Director of the Department of Radiation Oncology at the University of Maryland Medical Center. Dr. Nichols, welcome to Housecall.
Thank you for having me.
Our pleasure. So briefly tell our viewers about your professional background.
Sure. So I did my radiation oncology residency at the University of Maryland and was fortunate enough to stay on as faculty there as well. I also am a Maryland native, so did my medical school training also at the University of Maryland. So certainly want to give back to my community and the people that are here. And at the University of Maryland, I specialize in both breast cancer and GYN cancer treatments using radiation.
Very interesting.
Yeah.
So tonight we're going to be focusing, of course, on breast cancer and new treatments. And our viewers, I'm sure, are aware that in terms of broad brushstrokes, the treatment options for cancer in general and breast cancer in particular include surgery, including lumpectomy, chemotherapy, and then radiation therapy. So let's focus on radiation therapy.
Okay.
What exactly are the pluses and minuses of radiation therapy when you're treating breast cancer?
Sure. So generally speaking, radiation can be used in two settings for breast cancers, and we typically divide them up into early stage breast cancers and more advanced breast cancers. So for early stage breast cancers, as you mentioned, one of the surgeries that is often done is a lumpectomy, which is removal of the lump plus a little bit of tissue around that. When we do a lumpectomy, we always give radiation therapy afterwards in order to prevent the cancer from coming back. So there were some studies done many years ago where half the patients got the lumpectomy only and half the patients got the lumpectomy plus radiation. And actually, to be honest, there was another arm in that study where women had a mastectomy as well. Okay. And adding the radiation in very clearly showed a benefit in terms of preventing the cancer from coming back. And that made that equivalent actually to a mastectomy. So for women who have a lumpectomy, we always advise, for the most part, that they receive radiation therapy. As everything is continuing to move forward with breast cancer care, we are finding possibly some patients that may not need radiation therapy, but I would say that's not necessarily the standard right now. We more often do recommend radiation therapy. But certainly there can be some side effects to radiation therapy treatment for women, both short-term as well as some long-term side effects as well. And typically a radiation oncologist would talk with their patient about kind of the pros and cons of those. But again, our most important thing is to always look for cure for these women.
When you do post-operative radiation therapy, do you focus the radiation only on the remaining breast tissue, or do you also extend it into the axilla, the armpit, where, as you know, some of the draining lymph nodes exist?
Right. So again, that would depend on each woman and kind of their stage of cancer. So generally speaking, we're always targeting the remaining breast tissue. And then for certain women, we are also including some of the draining lymph nodes, which actually may not just be the axilla or the armpit, but also the lymph nodes below the collarbone, above the collarbone, and then sometimes even beneath the breastbone, which we call the internal mammary lymph nodes. And so all of that really depends on the size of the patient's tumor, if they have any lymph nodes involved with cancer, and so forth as well.
So at this point, is it fair to say that the large majority of patients who get lumpectomy also will get radiation?
Yeah, so I would say, especially in our country, almost all women who have a lumpectomy are recommended for radiation treatment afterwards.
Okay. So there is now a new technology called proton beam therapy. Yeah. Explain to our viewers what exactly is proton beam therapy.
Sure. So proton therapy is a different form of radiation compared to what I usually call our regular radiation or photon therapy. Because the words are so similar, I usually call photon therapy regular radiation just so
Sure.
patients don't get confused. And so as you may see, when photons enter the body, they act very much like an X-ray. So they start off in the body a little bit weaker, get strong a couple centimeters in, and then they continue to kind of pass through the body, getting weaker and weaker and weaker as they go. For proton therapy, it starts off in the body a little bit weaker, which we don't worry about so much. It gets strong exactly where we tell it to, and then it stops. And so in particular, the area that we find that can be beneficial is in what we call the tail region of the X-ray therapy. And oftentimes for breast cancer patients, what's in that area are the lung and the heart tissue. And so for many women, we find that we can decrease exposure to the heart and the lung a little bit better with proton therapy than with photons.
And of course, this would be a bigger concern, I would imagine, if the cancer is in the left breast, because of its
right.
proximity to the heart.
That's exactly right, because
Yeah.
the heart certainly lies more on the left side of the chest. So we definitely think about it more in women who have left-sided breast cancers. And then also, as we mentioned earlier, we do have one of those draining lymph nodes underneath the breastbone, which often lie right in front of a woman's heart on the left side. And so we also think about it a lot for women when we're giving them nodal radiation on the left side as well.
So given that there is a lesser dose, so to speak, with proton therapy versus more conventional radiation therapy, how do you pick and choose your patients, or do you think everyone should go to proton therapy?
Yeah, so it's a good question. And so I think you could talk to a couple different radiation oncologists and get slightly different answers. So our approach at the University of Maryland is that we don't necessarily think protons is beneficial in every patient. So the patients that we think about it a lot are first in women who've already had radiation to the chest one time around, whether that be for a breast cancer or a lymphoma or any other type of cancer that they may have had in their past. Anytime we're giving radiation a second time around, we really want to try to minimize the dose to some of the other organs as much as possible. So after that, I then think about it in women who do, as we mentioned, have left-sided cancers and need nodal radiation, or also in women who in particular have a lymph node that they couldn't remove at the time of surgery that might need to have additional radiation treatments delivered to it, or what we call a boost. So oftentimes it's safer for me to boost those areas with proton therapy than it is with photon, because inevitably many of the times those lymph nodes lay in front of the heart or by the brachial plexus, which are the nerves that connect to the arm and allow our hands to function. Lastly, we also think about it a lot in women who maybe already have a lot of heart issues. So sometimes women actually develop heart failure as a result of their chemotherapy for breast cancer, and they might be very symptomatic from that. And so in those cases, we really want to do everything we can to minimize dose to the heart.
We have discussed, of course, post-operative radiation and or proton therapy. Have you ever found that a surgeon approaches you and say, I'd like to do a lumpectomy to minimize the morbidity, the damage to the breast, but it may be a bit challenging, it may have already involved the chest wall. Do you ever consider preoperative therapy to shrink down the lump to make it easier for the surgeon?
Yeah, so it's a great question. So in breast cancer in particular, oftentimes when we are in that scenario clinically, which to be honest does happen, where it's either involving the chest wall or sometimes the skin, I'd say the standard in breast cancer still is really to consider chemotherapy first, which we call neoadjuvant chemotherapy. In those settings, if we give the chemotherapy and then we see either little response or progression of disease, which fortunately is pretty rare, then sometimes we actually do come in and give radiation before the surgery to hopefully help make that patient more resectable. Again, fortunately, I'd say that scenario is more rare nowadays because the chemotherapy agents are very good now.
Sure. If somebody gets more conventional, if you will, old-fashioned radiation therapy after a lumpectomy, what kind of side effects can they anticipate?
So typically with radiation, we break the side effects up into kind of short and long-term ones. So the short-term ones that all women get are some fatigue, which usually I tell patients, you're going to wake up feeling good in the beginning of the day, but the fatigue tends to come on towards the end of the day, where women often just say they run out of steam a little bit earlier. That generally resolves within about 4 weeks after the radiation is done. The other side effect that all women get during the therapy is a skin reaction. So depending on someone's natural skin tone, that can have a little bit of a variety, including sun or tanning, basically like a suntan, more like a sunburn where the skin turns more pink in color. Sometimes like a bad sunburn, people can have where that top layer of skin kind of flakes off.
Sure.
And very occasionally someone can have a little bit of a deeper peel where it looks a little bit raw underneath. Fortunately, when that happens, those areas tend to be small and localized and tend to happen in the armpit area or kind of under the breast in the inframammary fold. And part of that's also just because our clothes rub there more, a bra rubs there,
Sure.
your pocketbook. All of those things generally resolve pretty quickly after the radiation is done. When it comes to long-term side effects, the couple things that we usually focus on for breast cancer patients, one is the heart, as we've already mentioned. So we do know that radiation can be a risk factor for developing heart disease down the line, just like hypertension, diabetes, high cholesterol, except, we can't give patients a pill to fix that.
Sure.
And so there's an increasing amount of studies that have been published over the last couple years really correlating the dose of radiation to the heart with an increased risk of heart disease down the line. So that's something we're paying attention to a lot now, and all radiation oncologists now really focus and document the radiation doses to the heart that we see, and there's a variety of ways we can help try to decrease that. Another common side effect people can have, not just from radiation but also from the surgery, is lymphedema or swelling of the arm. So radiation can increase that risk slightly as well. Typically we quote about 5 to 6% now in really the modern studies. And so that's something we're always looking to improve upon, because certainly lymphedema can really affect women's quality of life.
Sure. Lymphedema being, once again, swelling of the arm. You mentioned the heart effect. Circle back to the lungs. Do they get so-called radiation pneumonitis, where the lung becomes inflamed?
Yeah, so that's another good point. So there is something called radiation pneumonitis, as you mentioned, and so that can happen when the lung tissue is actually trying to heal from radiation. Fortunately, in breast cancer patients, the incidence in the modern day is very low. So the more recent studies are showing an incidence only of maybe 1 to 2% for patients, unlike lung cancer, where that can be a much more common side effect that patients experience. Generally, radiation pneumonitis, when we see it in breast cancer patients, is most often asymptomatic. So it might be something we actually detect incidentally on a CAT scan and needs no treatment at all. Very occasionally, we do have to give women steroids. I'll say in my experience so far...
Steroids being an anti-inflammatory.
Sure, yes,
right.
Anti-inflammatory. And in my experience so far, I actually maybe have only had one patient who's had that, again, just because it tends to be pretty rare now.
Sure. Now, we have a little over a minute before we go to the break,
Okay.
but we've talked about the side effects of classic radiation therapy. So how does the safety profile, therefore, compare with proton therapy?
Yeah, so with proton therapy, one thing I generally do find in my experience for our breast cancer patients is that the dose to the heart is much less. Now, I would say today we don't really know exactly what that's going to mean long-term for women. So there's actually 2 national studies that are open, really trying to show that that decreased radiation dose to the heart that we do see with proton therapy is actually going to translate into a decreased risk of heart disease down the line for women. But I would say the data that we have so far supporting that is strong enough that we're pretty confident we are going to see that. The short-term side effects, otherwise, I tell women are usually about the same. So I don't really see better or worse fatigue, and the skin reaction also is not really better or worse for patients. So the short-term side effects generally are about the same as well. And then when it comes to the lung as well, for many patients we do see a decreased radiation dose to the lung, but I'd say there's even less data to really know what that means for women, and especially because it's so rare to begin with, I think it's going to take some time to really find that out. Yeah.
Sure. Well, terrific. We're going to pause briefly for a break. When we return, more with Dr. Elizabeth Nichols and we'll be discussing a brand new treatment, Gamma Pod, to treat breast cancer. We'll be right back.
A single ember from a wildfire can travel over a mile. You can't control where it will land, only what happens before it does. Visit fireadapted.org to learn how to protect your community from wildfires.
We're back. My guest this evening is Dr. Elizabeth Nichols of the University of Maryland Medical Center, and we are discussing Gamma Pod treatment, a new treatment for breast cancer. Dr. Nichols, before we pause for the break, you mentioned that one of the side effects of classic radiation therapy or proton therapy for breast cancer is fatigue. Why the fatigue if the radiation treatment is only localized to the breast tissue?
Yeah, or any cancer patient becomes fatigued during radiation. The data that we do have seems to indicate that when people get radiation, there is some sort of systemic release of different markers in the blood that we call cytokines and so forth, that also are very similar to what can be released when someone, say, is sick with a cold or a flu. And we do find that that release is somehow responsible for the fatigue. There are some things that can help people with the fatigue, though, and even though this might seem a little counterintuitive, actually the best thing for patients to do is actually to remain active. There's actually been some studies that have looked at moderate amounts of exercise during radiation, and all of that has seemed to indicate that that can actually help improve patient-reported fatigue, or subjectively what the patient feels. Other things too, such as acupuncture, have been shown to be beneficial, in yoga as well. And so certainly if women are having a hard time with the fatigue, those are some of the things that we talk about.
Sure. So let's shift gears then to discuss Gamma Pod treatment. First of all, what exactly is Gamma Pod treatment?
Sure. So the Gamma Pod is a new device that was developed at the University of Maryland by my chairman, Dr. Bill Regine, and one of our medical physicists, Dr. Cedric Yu. And what it is a way to deliver what we call stereotactic radiation to the breast. And it's a machine that's really dedicated and designed just for the treatment of breast cancer patients.
So this is unique to the University of Maryland.
So we are currently the only institution that has the Gamma Pod. However, we have developed a scientific consortium, which we call the Gamma Pod Research Consortium, or Coalition. And so there are, including University of Maryland, 4 total institutions that ultimately will have the unit by the end of this coming year. So ourselves, UT Southwestern in Texas, Allegheny General in Pennsylvania, and then actually Ottawa Cancer Center in Ontario, Canada as well.
So it's an international study.
It is, yeah.
Yeah, very nice. And why is this basically taking the proton therapy and adding a stereotaxic unit to it?
So it's a little bit different than that. So for breast cancer, most women in our country at least are diagnosed in the early stage. With early stage breast cancers being so curable, a lot of the focus on research has focused on maintaining cure, but minimizing side effects as well as improving convenience for women. So I'd say over the last several years, there's been a lot of movements in different ways to do that. So one has been moving towards what we call the short course of radiation, where instead of giving 6 weeks of radiation for all women, we now narrowed it down to 3 to 4 weeks. Another way to do that is also by what we call partial breast radiation. So instead of giving radiation to the entire breast, focusing in on the highest risk area, which tends to be the lumpectomy cavity, or where the tumor was removed, and that rim of tissue right around it. The Gamma Pod is really an extension of partial breast therapy, where we can deliver basically partial breast radiation to either the lumpectomy cavity, or if the tumor were intact, we can do that as well. And we've done a lot of comparisons with the Gamma Pod and some of these other technologies, and we find that the Gamma Pod can be superior to those other technologies in terms of delivering dose to the other parts of the breast as well as some of the other organs. And so we think that the Gamma Pod will continue to move us in the direction of further decreasing side effects, improving cosmesis, or how the breast looks afterwards, and then also continuing to improve convenience for patients, because we would be able to deliver the technology and the treatment in as few as 1 to 5 treatments.
Wow. Now, explain to our viewers what you mean by stereotaxic.
Sure. So stereotactic is something we use to describe a lot of different types of radiation, where we're giving a high dose of radiation in a very conformal way, meaning to usually a target that's somewhat doesn't have a lot of edges to it, essentially. We also have what we call a rapid dose fall off, meaning when you go from one point in the tumor to even a centimeter away, there's almost no radiation, or the radiation decreases very rapidly. It's also when we deliver it in a few fractions, and then we also have the ability to target and localize the area that we're treating. So it's a technique that's actually started off in brain cancers or brain tumors. It was so successful there that it then got moved to lung cancers, and now it actually can somewhat rival surgery for early stage lung cancers in terms of the control that it provides, but improving, again, side effects. We also use it in liver tumors, and believe it or not, we actually use it in some metastases, or when the cancer has spread to another part of the body. It's actually been used. So it's actually been used in breast cancer metastases, say to the lung and the bone.
Right.
In the past, it really hasn't been used for the breast because we didn't feel we had a very good way to immobilize the breast. So, you know, the breast is a organ that sits on top of our ribs.
Sure.
It can move with our breathing. And so we've never had a really good way to really immobilize or keep the breast still. And so one part of the gamma pod system actually is an immobilization system that helps keep the breast nice and still so that we can then deliver this technique of therapy.
And do you get a good three-dimensional view of the lump, and then you're able to paint it, if you will, with the beam?
That's exactly what happens. So with the gamma pod, we put on the immobilization device so the breast is not moving. We then do a planning CAT scan, very much like we do for any other form of radiation treatment delivery now, with that immobilization device on. The patient then receives the treatment with the immobilization device on. And so we have those CAT scan images, and we create the radiation plan based on those images. And then you're exactly right that the dose gets painted to the tumor or the lumpectomy cavity.
Now, to be clear, though, the technology you're using with the gamma pod is proton?
No.
Or is it classic radiation?
So it's actually gamma rays, which is
a
part of
third
the
technology.
name. Kind of, yeah. So
Yeah.
part of that's actually partly where it gets its name, gamma pod.
Right.
So gamma radiation comes from cobalt-60, which is a natural source of radiation. So that was actually the first way radiation was delivered through machines, worldwide many years ago. That type of radiation has some pros and cons to it. One of the cons being that every 5 years you have to replace it because it decays. That's when it meets its half-life. So it's really only used, at least in our country now, with the gamma knife or the gamma pod would be the second technology. But it's very similar to our regular radiation or photon radiation in terms of the physics of how it works.
So I guess the big question for us tonight and for you back at the University of Maryland is when you have a patient with breast cancer, should they consider classic radiation therapy, proton beam therapy, or now this brand new elegant gamma pod therapy?
So again, it's going to really depend on each patient. And so usually, or I guess I would say fortunately for me, since I have experience in all three technologies, usually when I have a patient that comes in to see me, I'm actually going to be in my head evaluating them as I gather their information and talk with them about which therapy actually might be the best therapy for them. Generally speaking, we envision the gamma pod as really being more for early stage breast cancer patients. I usually think about proton therapy more in advanced patients, or again, patients that may have already had radiation one time around. But then certainly regular radiation, there's still going to be a home for that for our breast cancer patients as well. So not every woman is eligible for partial breast radiation. And as I mentioned before, gamma pod's really a form of partial breast radiation. Our National Society has some pretty clear guidelines on which women are the best candidates for partial breast radiation. And so I would say for many women who still have early stage stage breast cancers, they may not be a good candidate for partial breast radiation for a variety of reasons. You know, some of the things might be the size of their tumor, it might be a little too big, or they might have some other higher risk features at the time of their surgery that still make them early stage, but make us a little bit worried that their cancer might have a higher risk of recurrence. And so those women, kind of our standard radiation might still be the best for them.
Have you found that if somebody has already embarked upon standard radiation, post-lumpectomy, and now there is a question of local recurrence, that there are people who break through on standard but will respond to a more focused gamma pod treatment or proton therapy?
Yeah, so it's a great question, and I would say we don't know the answer to that yet. It's certainly something that we're actually very interested in studying and looking at. You know, when we're giving regular radiation, it's a smaller amount per day for, you know, a longer time frame. And we do know from some laboratory studies, not just on breast cancer, but some other cancers, that harnessing kind of a stereotactic approach in some cancers can actually result in a better response. Or similarly, proton therapy, the physics of how it works actually in the cancer cell, that there might be some difference there as well. And so I'd say that's an area of active research and something we're very interested in looking at further.
Has there been any interest at looking at these technologies as being additive? Maybe giving the same patient the same treatments, maybe alternating them or something?
So not to my knowledge, we haven't really looked at that. There are some cancers where sometimes we give part of their treatment with photon therapy and then part of the treatment with proton therapy. In breast cancer, we haven't really looked at that too much yet. I would say the one area where some of our thoughts are going in terms of being additive would be for women who actually have metastatic breast cancer or stage 4, where normally the main part of their therapy is chemotherapy. And everyone's kind of heard about immunotherapy. And there's actually been some suggestion that when we add radiation in, particularly for immunotherapy, that even if we just target one spot of their cancer, it can actually allow their whole body to respond better. So I'd say that's the one area that we're very interested in looking at using radiation, any of these forms, but in particular, actually the gamma pod. We're interested in looking at that as being an additive therapy in those women.
Okay. Very briefly, we have 1 minute left. So what exactly is thermal therapy?
Yeah, so thermal therapy is kind of the medical term for that is hyperthermia. And it's a heat therapy that we can actually use in combination with radiation therapy to make the radiation more effective. So the way it works, so all of our DNA in our body has these protective proteins around it, which we call heat shock proteins. And believe it or not, if we actually heat the DNA or heat the patient's skin, it takes those proteins off and allows the DNA to be more susceptible to the radiation damage. And so it's something that, in particular for breast cancer patients who've had recurrence on the breast or the chest wall, there's been some studies that looked at where half the women got thermal therapy and half the women just had radiation along with the thermal therapy. And we actually found that their cancers responded better when we added the thermal therapy in. One of the interesting things about the thermal therapy, though, is it's not good to give it every day. So what we actually find is a patient's body catches on that they're getting the heat therapy, and so their body actually upregulates those protective proteins around the DNA.
I'm unfortunately going to have to stop you there. But Dr. Nichols, if our viewers have any questions, how can they reach you?
So they can reach me at the University of Maryland. I have my email provided, I believe, on the screen, but it's enichols1@umm.edu, and I believe the phone numbers are there as well.
Dr. Nichols, thanks for joining us on Housecall.
Yeah, thanks for having me.
My thanks to Dr. Elizabeth Nichols for a terrific interview. My thanks to my team here at the station. And most important, my thanks to you, the viewer, for welcoming us into your home. Let us know how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be a very interesting one. Dr. Bart Radolinski, a noted urologist here in Montgomery County, will be discussing urologic issues, focusing on the kidney, prostate, and other topics. It's going to be a great show. See you then next time for another edition of Housecall. Good evening.